recording right now. Hello, everybody, and we are going to officially initiate the 4th Journal Club of SELA and the 30th Journal Club of Tehran University of Medical Sciences. This is a joint meeting between the Latin American Federation of the Endodontic Society. So on behalf of the SELA, the Society of the Latin American Associations, Endodontic Associations, we have Professor Carolina with us. So Professor Carolina, the stage is yours to introduce our guests, and we will carry on.
Thank you, Dr. Nekoofar. Buenos días, Latinoamérica. Good afternoon to the rest of the world. On behalf of SELA, I would like to welcome you all to our monthly session of the Praise to Raise project. We are starting this year with the conviction that this wonderful project will continue to grow and reach even more colleagues from Latin America and other parts of the world. Our special guest today is Dr. Fahad Alzoubi, who is chair of the Faculty of Dentistry at the Kuwait Institute for Medical Specializations. Dr. Alzoubi obtained his Master on Clinical Dentistry and Endodontics degree from the King's College of London. He also has fellowships from the International Association of Dental Trauma and the Royal College of Surgeons of Edinburgh. He has been involved in educational experiences in Kuwait and Dubai and clinical practice in several institutions. We would be discussing his recently published article entitled Postoperative Pain in Non-Surgical Root Canal Treatment After Sealer-Based Obturation versus Worn Vertical Compaction, a randomized clinical trial, which can be found in the International Journal of International Endodontic Journal. And of course, we would like to thank Professor Mohammad Nekoofar for being the promoter and leader of this project and share all his experience with us. Dr. Nekoofar, please start the session.
Thank you. Thank you very much for your introduction. So this is my pleasure actually to have my colleagues from Kuwait and all other colleagues from around the world, from Latin American and other countries. So today actually we are very excited. So we are going actually to talk about an article which is recently published in Journal of Endodontics. Sorry, in International Endodontic Journal, sorry. My fault. And actually, you guys all know that this type of publication is a big issue and sometimes very difficult to do such a things. But our job in this program is actually to critically appraise our colleagues that they publish something. And the reason for that is actually to help other young fellows when they want to start doing some research to know the methodology and to know how to deal with the methodology. And also, when they read an article, they should be able to read the article in a critical appraisal way, rather than just to read it and imagine that this everything in any article is true. It is not that. It is actually always on the very important peer-reviewed from around the world. And we have an eagle eye here, Professor Hugo from Mexico, that Hugo is actually going word by word in any article and looking at any part of the article. So be very careful when you publish something, we are looking at that. Okay, today I want to get permission from Dr. Fahad to be harsh to him and put him in a very hot chair, asking him difficult questions. Professor Fahad, by your permission, I'm going to start giving a summary of your study, which is an amazing job, by the way, that you compare the postoperative pain after root canal treatment using two different techniques, obviously sealer-based obturation versus warm vertical compaction. I think sealer-based obturation, especially using calcium silicate sealers, these days is actually a very hot topic in all the endodontic articles and publications. So there is a trend for this type of things. But doing a clinical trial, like a parallel two-arm, double-blind, randomized clinical trial, is a very, very difficult job to do. And you need to keep an eye on every details of that, which my colleague in Kuwait Professor Fahad did that very well. So they were looking for the post-operating pain and analgesic intake of the patient, which is one of also very, very important issues for a clinician. So I would say that this article has a very high level of the evidence, give us a lot of information based on the level of the evidence that they generate for us. So calcium silicate sealers, and so we use the single cone with them, and we call them sealer-based obturation versus the conventional techniques like warm vertical compaction or lateral compaction. This comparison can give us a lot of information. Especially post-operative pain is one of the big issues that we were always worried about that. If we look at the introduction of the article, we will see that the post-operative pain prevalence in root canal treatments based on a lot of things can be between 3% to 58% of the cases that we did root canal treatment for them. And root filling technique and sealers can be the key factors. And in this study, the authors try to solve this issue for us. And the novelty of this study is focusing actually on the sealer-based obturation versus warm vertical compaction using resin-based sealer. So if you look at the SBO, that means we are talking about the sealer-based obturation here. And then CSS is actually using the calcium silicate sealer or hydraulic calcium silicate sealers, which we will talk later about the details. And then warm vertical compaction, abbreviated by WVC. And then RBS at the end of this sentence is actually resin-based sealer. So from now, we will use this abbreviation. So when we look at the research gap and based on the article, the authors mentioned that the limited direct comparison between sealer-based obturation and warm vertical compaction in the previous article was the research gap. They were looking for that. Obviously, when they want to start such a things, they need to calculate the sample size. And this one was based on the main goal of this study. And in the study, we find it out, this is just the tip of the iceberg of this amazing clinical trial. And we should wait for the future publication from this very organized group, actually, because we will ask Dr. Fahad about what they did about this one. Dr. Fahad, I understand you start actually a very big clinical trial, and then you just publish some part of that for the post-operative pain. Am I right?
Yes, Professor Nekoofar, you're absolutely right.
So can you tell us a little about the history of why you start this study, how you start this study, how do you manage that, and give us some quick idea about that.
Well, first of all, I would like to thank you for this invitation. And I've had a look at your previous guests, and I believe I'm the first one from Kuwait.
Yes,
so I'm privileged to be so. So thank you very much. I extend my gratitude to your colleagues, and I hope we do have a fruitful conversation today. And your criticism is not only accepted, but actually encouraged. As I say to my postgraduate students, during our journal club sessions, authority goes out the door. You're here to ask questions, and nobody is right. So you're absolutely more than welcome to criticize my work as much as you like.
Perfect.
So back to the
explanation. Authorities goes out. Perfect. I love
absolutely. When science comes in, authority goes out. Yes, we started this project as I mentioned before we went live. We started during COVID around 2021. We did start the work in terms of ethical approval, etc., a year before, and then we got hit by COVID. But thankfully, we managed to start it anyhow. As I explained in the article, it's a clinical trial that is going to look at the clinical and radiographic outcome endodontic outcome comparing SBO with worm vertical compaction. The main reason that we address this question is, as you mentioned in the introduction, sealer-based obturation is becoming increasingly popular now. For many reasons. It's much easier, it's less technique sensitive, and it's less time consuming. Unfortunately, with any new technique, you get a lot of hype around it that is not based on science. You get a lot of marketing from companies. So I thought, as amazing as the basic science research that is published in this area, very little prospective randomized controlled clinical trials actually addressed this issue in the way that I would love they had. So my colleagues and I decided to tackle it ourselves. We contacted our colleagues from UPenn, which we have established a relationship and research since then. And we got Frank Setzer on board, who probably some of you have heard of. We used his experience in carrying out randomized controlled trials, his experience in CBCT trials, and we insisted that outcomes, not only radiographic outcome, would not only be assessed by 2D radiographs, but we insisted that CBCT would be the main outcome measure. And that's what really sets it apart. So you will find some articles published. Most of them used only 2D radiography. One by Zavattini and my previous boss, Francesco Menocci. They did use CBCT, but their trial was not randomized. So there was a gap in the literature that I would have loved to have read for me to be comfortable using the sealer-based obturation, and that's how it was started.
Perfect, perfect. So I just showed some of the previous studies. As you mentioned, for example, the time of the observation in some of them are very short. Like if you look at the Kim et al. 2022, you will see that they also compared SBO with CSS and warm vertical compaction, almost same, but the shorter observation period, 48 hours. Or if you look at the Yu et al., you will see the different methodology in most of them. And one of the advantage of the study by Dr. Fahad and his group is actually the duration of the post-operative evaluation for the pain, which was like a week. So it is also important to know what happened for pain or post-operative pain after 7 days, which is also very good to look at that. However, Dr. Fahad, one of the questions that we have received is, although we know that the strength of your research is about the clear research question and relevant background on CSS and RBS in the introduction, but if we look at the novelty of the study, we are a bit worried about, because we have a lot of the studies, previous studies that they did almost the same things. But you already mentioned that you are looking for some specific situation in addition to the CBCT evaluation. Do you want to add anything about the novelty of your study?
Absolutely. I mean, when I talk about CBCT, it concerns the second part of our trial, which is going to be published, because CBCT wouldn't really make a difference in post-operative pain. So if I wanted to concentrate on this paper only, I would say that I probably mentioned this in the discussion. Similar articles had, if we look at Kim, for example, they've included the non-surgical root canal treatment and retreatment. Their observation period was 48 hours only, as opposed to the 1 week that we did. I think you, et al., did not have any sort of randomization, and they had quite a low response rate. I think personally that we managed somehow to address a gap in the literature in that way. Furthermore, another question that I had, and I certainly had as a comment from the reviewers, is that why wouldn't you combine this with your outcome study and publish it as one manuscript?
Yes.
So if you allow me to answer this question.
Yes, please, please.
The answer really, I mean, when we start planning the trial back in 2020, myself and the co-authors decided to have two separate manuscripts for two main reasons, really. The first one is that we believe that postoperative pain is an important topic that merits publication by itself. And the second reason, and frankly, I think is the most important reason, is that we would have the data available much more earlier than the data for the outcome study. Therefore, there's no reason to hold this data back and prevent this dissemination or delay the dissemination of information while we wait for the outcome study. So these are the two real reasons that we haven't combined them in one manuscript.
Yeah, but I do agree with you that the post-operative pain is one of the very important things for us. It is like a quick achievement for us because many of our patients come to our office or come to our clinic just for relieving the pain. So we are very worried about this issue, definitely. However, about your methodology, when we discuss, we have some concern about some part of that directly related to the pain. Let's move on and find it out. Hugo, do you want to add anything about the introduction? Because I want to go to the methodology part. Anybody from the audience? If anybody from the audience have any question, they can raise their hand, turn on their videos, turn on their microphone. Nope, good. So far, it is clear. So the design of this study is double-blind randomized clinical trial, and the population inclusion criteria is patients aged from 16 to 65 with restorable permanent teeth, obviously, and the exclusion pregnant women, teeth with advanced periodontal disease, resorption, non-restorable, etc. So sample size was 212 teeth from 195 participants, which looks actually a good number of in terms of the sample size. However, actually, we need actually to do some more precise sample size calculation. And they did a good ethical approval. Obviously, the ethical approval for this type of studies also very, very important. And then treatment protocol was standardized instrumentation for randomly selected patients, ProTaper, Next, rotary files, chemomechanical disinfection with sodium hypochlorite and ethylene EDTA, and then root filling. So they actually separate them and then they put them in two arms randomly again, and they allocate them blindly using total fill BC sealer and gutter, single cone gutta-percha, obviously. And then the other group, warm vertical compaction group with AH plus sealer as a resin-based and a standard resin-based sealer with warm gutta-percha compaction. And I think as one of the ex-student of Professor Marucci, Fahad and his group was expert actually for doing warm vertical compaction. And then they evaluate the post-operative pain assessed at 1, 3, and 7 days using actually the numerical visual analog scale that we will talk about that later. So if we look at that methodology by a critical appraisal way, I would say that the strength is appropriate randomization and blinding, which is very important. Because imagine in the future, if somebody wants to do systematic review and they will select your study, Fahad, the first things that they look at that is randomization and blinding. And believe me, as one of the member of the board, of the editorial board of International Endodontic Journal, we are very, very precise about these details, and they should follow every step of the guidelines that we publish in the IEJ. So I'm sure Fahad did that. And the most difficult part in terms of publication in International Endodontic Journal is this part, to follow the guidelines to make sure that all the publications are at the same way. So in the future, whoever wants to do meta-analysis or systematic review, they can easily extract the data from the published article. So they did the standardized clinical protocols, or they followed the standardized clinical protocols as well as the standardized publication protocols as well. Before I go to the weakness, I want to ask Dr. Fahad about his experience for submitting the article in IEJ and the difficulty of that Was it easy or difficult, or following the guidelines? Was it easy, Fahad, for you or not?
I mean, as I always say to anyone who's doing research and applying their work for publication, there's no such thing as an easy application. It never exists. And the more difficult it is, the better the journal. It was difficult. I mean, it's not an easy journal to apply to, but I have to be honest, it was properly difficult. It was not outrageously difficult. 99% of the points they raised were valid. I mean, when I was younger, I've had experiences with less known journals that were just difficult for no apparent reason. So yeah, overall, it was a very pleasant experience, and I look forward to applying more manuscripts.
Good to hear that. Good to hear that. So talking about the weakness part of the study, I want to ask you some questions. First, sample size being powered for primary outcomes rather than the pain. So I may say that, or somebody may say that, okay, you calculate your sample size for the outcomes that you already mentioned on CBCT or on radiograph, or about the lesion, preapical lesion, everything. So maybe because the results showed that there wasn't any significant difference between two groups, maybe by more sample size, you will solve this problem as well, or you may be able to find any difference between two groups. So because of that, I was a bit worried when I look at that, and I think Hugo also had same issues about the sample size being powered for primary outcomes rather than the pain, specifically for the pain. And then when look at for that, also, we find it out there is unequal preoperative pain measurement. So especially, I think in the group that you use calcium silicate sealers, the preoperative pain was higher than the group that you filled with warm vertical compaction. So what do you think about that? So the question actually raised from that is the possible impact of prior medication on postoperative pain and also on the sample size. So in the inclusion criteria, we find it actually, we couldn't find something about the use of analgesic or antibiotics for the patient as well. And do you think it may have some co-funding effects on the result or not?
All right. I think you've asked a number of questions, so I'll try to answer them.
Yes. Let me go back to the previous slide for you to make it easier for you. So start by...
I think I remember them.
Okay, start by sample size.
Your first question was about whether you're concerned that the study might be underpowered.
Exactly.
And it's a very, very, very valid concern. I personally myself had this concern when we were planning for the study, and I sat with a statistician. I said, our sample size is based on the outcome rather than a clinical outcome rather than the postoperative pain. Would this affect our sample size? And then he went away for a week or so, and then he came back and he said, I've researched all trials published that looked at similar questions, and our study is going to be the highest sample size. So if it is underpowered, it's the best underpowered trial there is in terms of sample size. And because our main aim is to look at the outcome, we sort of accepted that there might be a small chance it is underpowered. However, compared to similar studies, the sample size is actually bigger. So, I mean, the only defense I have is this. But otherwise, yes, I do share a concern as well.
That's good. Good to hear that. Good to hear that. Just, I don't want to interrupt you, but let's finish the sample size issue, because when you mentioned that, I have also checked the previous studies and I find the same things. But the only reason that I raised this question is because you just mentioned in your article that your sample size measurement was based on the primary outcomes rather than the pain. That was the only reason. Although Absolutely. This number was really good in comparison to all previous studies, it was really good. So the only thing is about the writing. So I would say that hopefully this appraise to raise program is going actually to clear that your study is really good in terms of sample size, although that may come to the mind that, oh, why they mention something for the calculation. My suggestion is if you because I know you are continuing this study, if you reevaluate the sample size by using the other studies rather than the pilot study by yourself, you will find it that your sample size is not unpowered or low power. So that's fine. Let's go to the next question.
So if you would kindly remind me of the second question, which is
Potential confounding effect of the unequal preoperative pain. That is the most important question to me, because if we look at that, you haven't exclude the patients that they use analgesic or antibiotics before coming to your clinic.
Absolutely. So let me sort of divide your question into two questions and answer the first part of it, which is the significant difference in preoperative pain between the two groups. I mean, we were lucky enough that other confounding factors were evenly distributed between the two groups. My answer would be is that randomization, by definition, negates the control over confounding factors beyond inclusion and exclusion criteria. So what I have control over would be the inclusion and exclusion criteria. Anything else, really, I have very little control over. And unfortunately, this has to be accepted as a limitation from my point of view. And certainly, it might be a limitation. And I certainly mentioned this in the manuscript and the discussion as one of the limitations of the study. I think by having a number of confounding factors, ending up with just one that had significantly more in one group than the other, I consider this probably a bit lucky, on the lucky side. But other than that, really, there's very little control we can have over confounding factors if randomization was performed properly.
Yep, good. But again, fortunately, the group that they have more preoperative pain was the group with the calcium silicate sealers. So we cannot actually claim that, oh, maybe you were under the pressure of the companies to manipulate the data, because actually the group that they may have more postoperative pain are the groups that they have more preoperative pain, because we know that the only variable that we should be worried about that is preoperative pain. It has a direct effect on increasing more postoperative pain. But it happens in my mind to ask you a question. If a patient comes to our office with preoperative pain and we are worried about the postoperative pain, what should we do?
As I tell my patients, if you come in with preoperative pain, you have higher chances of having postoperative pain anyway, regardless of any obturation method we'll be using. So unfortunately, as we found out, that SBO will not overcome this this problem.
Yeah, good. So,
but you've mentioned the point about the companies. We were very, very strict about not having any sort of funding from companies, because it's our belief that even no matter how unbiased they are, having any funding will sort of create even unconscious bias. So we were extremely strict about this, and we were clear about our funding. It was from Kuwait Foundation for the Advancement of Sciences, which is a non-profit foundation. So there's absolutely no effect from any company whatsoever.
Very good to hear that. Very good to hear that. You know, Hugo, in our language, what we say in this situation, we said mashallah. So I should say mashallah to this group, because they did actually a great job, a great job by reducing this type of bias, because hidden bias is one of the things that we should be always worried about that in the clinical trials. Congratulations. So another question, in your methodology, you mentioned a force to standardize treatment protocols among providers. However, we find it out you and some of your students or postgraduate residents, they did the treatment. Can you explain about that? And how do you think this might have some impact on the consistency of the results and the treatment?
Absolutely. When we started planning for the study, this was one of the concerns, whether to include just students or students and faculty. And if we do so, how do we calibrate and how do we make sure that this doesn't affect the outcome? And the main things that we did to overcome this issue was, as I mentioned in the manuscript, as a primary investigator, before the start of the trial, I did a 1-hour seminar with all treatment providers. These are faculty members and postgraduate residents on how to use the SELA-based obturation system. You might think that everyone knows how to do the SELA-based obturation. It's a straightforward procedure, but you'd be surprised how different people use it. So I wanted to make sure that everything was standardized. In addition, every treatment provider carried out at least one case of SELA-based obturation after this lecture under my supervision to make sure that they are consistent and they conform to our guidelines in terms of the SELA-based obturation. In terms of faculty versus residents, some of our faculty actually, because they've been practicing for many years, they didn't actually use SELA-based obturation. They were against it. They kept using warm vertical compaction. So they were actually treated as residents because they haven't used it before. Those who did, surprisingly, we've just had the results now, and one of the things we looked at was whether there's a difference in outcome between residents and faculty, and thank God it was equal. My worst nightmare was that our residents were better than us. So yeah, so I think in terms of consistency between faculty and residents, I think we've managed to overcome this problem.
Great. What about making it multi-central? Because sometimes to overgeneralize the result, because the population that you did treatment for that, I would say that the diversity was very, very small. So if you want to overgeneralize the result, you may think about making it multi-central. And as I can see in the participants here, we have people from Pakistan, from Finland, from Latin American countries, everywhere. So you can choose other centers, even among us or somewhere else, to think about make it multi-central. Because I believe a multi-central, let's say 10 centers, they can do this type of treatment. Because if the operators or treatment providers are just very limited, or it just one person, we cannot actually somehow overgeneralize the result. What do you think about that?
I absolutely agree with you. And I think we've mentioned this. I don't think I've mentioned this as a limitation in this manuscript, but I certainly did in the manuscript I submitted recently. And this is an area for future research, actually, that I mentioned in the manuscript, that they start actually looking at this question using a multi-center approach instead of a single center approach. I absolutely agree with you. However, multi-center approach, as you may know, comes with its own challenges as well, and its own limits. It would come at the expense of calibration, for example. However, in terms of generalizability, I would definitely agree with you. I think the next step would be trying to conduct something similar using a multi-central approach.
Yeah, one of the aim of this type of gathering in Zoom-based meeting or journal clubs is actually to create a network between researchers around the world. And thanks to SELA and to the Mexican Endodontic Association for actually supporting us for this gathering, now the researchers can communicate with each other based on this type of networking as well. So we are looking forward to have more research together to get and to generate more scientific based data, as well as your data. Obviously, your data is amazing. Thank you. Let's move on. So Hugo, do you want to add anything so far? Because we are moving to the result.
I have a question.
Please.
My consent is the analgesic intake. No, this topic was taken. I have another question about the who was to collect the information for the patients, the results, the outcomes. was the same investigator who performed the clinical procedures or another clinician? O sea,
Absolutely.
ideally, the investigator who collect the patient-reported outcomes should have been blinded from the greatest extent possible, ideally.
So thank you, Hugo, for your question. Just to make sure that I understand the question properly, your question is who collected the data regarding the post-operative pain
Yes.
1, 3, 7 days later?
Yes.
Absolutely. So part of the grant we had was to pay a research assistant. So we had a full-time research assistant that did all this. She carried out the randomization, she carried out the follow-up calls and collection of data. And that's her job. That was her only job to do during the trial.
Okay.
No one had access to that apart from her. And basically all the data was submitted to her, and she placed it in a secure Excel sheet until the completion of the trial.
Thank you.
Yeah, that's great. That's great. So it looks like a triple blind study rather than just
Yes.
double blind.
Yes.
However, on the other hand, it's
Yes.
very difficult to make blindness for the operator because warm vertical compaction, the operator knows what to do. And also the sealer base, they're absolutely different. Even the patient can understand what happened for them. Have you managed anything to also blind this part or do some sort of cautious for that?
Well, I can be confident that the patients did not know which type of obturation system they had. I can say that with confidence. However, you are right, the clinician did know, but the clinician was not informed of the type of obturation until they were ready to obturate. So they've carried out all the steps necessary, and once they were ready to obturate, the research assistant went, looked at the computer and told them it's SBO time, it's WVC time. And that's when they knew about it.
Very nice. Very nice. Okay, good. Thank you, Hugo. So participants 160th in SBO group and 105th in warm vertical compaction, which is very good. And pain scores, we fortunately find it out that they couldn't find any significant difference in pain or analgesic intake between groups. And pain decreased over time in both groups. So I want actually to just add a very small question about this. How do you, have you managed to find it out? Because in the calcium silicate sealers obturation, we know that sometimes we may have puff of the sealer. Have you managed to evaluate the technical quality of the obturation on the postoperative pain as well or not? I'm not saying you should, but if you have done something like that, I'm very curious to know the result.
I mean, certainly we thought about that to include the puffs and look at postoperative pain in that direction. The group, I can't remember who was with it and who was against it. But I remember myself, I was a little bit against including cedar puff for one main reason. I think that if you look at the literature, there seems to be conflicting results in terms of postoperative pain and puff. If we include it in the literature, I was worried that we might deviate the reader from the main issue, which is the type of obturation rather than the puff. So we might cause more confusion than is necessary. So we as a group decided not to look at that. We did mention that possibly later on, our residents could carry out a retrospective study looking at that and seeing whether they could see puff and the effect of postoperative pain. But in terms of our clinical but in terms of the prospective trial, we wanted it to be as concentrated as possible and not to deviate the reader from any of our main points that we wanted to show.
Perfect, perfect. And retrospective, looking at the result is also a very good idea. But not just to have some fun, that you generate some information and you want actually to extract everything out of that, published 100 articles out of it. Good, good, very clever, very clever.
Yes.
Okay, so Also, another important thing that the authors find is about the significant factors about the age, preoperative pain, and apical diagnosis correlated with postoperative pain. And now a good news is that they want actually to do some retrospective evaluation to give us some more information in the future. We are looking forward for that as well, Fahad. Okay, so younger patients in this study tended to experience higher levels of postoperative pain compared to older individual. So that's a good news, by the way, because we prefer actually to have more relief for our seniors comparing to our juniors. But how do you explain that? How do you justify such a thing?
I'm not sure how I can justify this without having an opinion about the younger generation. To be honest, the data was clear in terms of the effect of age, and we looked at whether age was simply a confounding factor, and it's actually they had more pre-op pain, but that wasn't the case. It was age alone that was a significant factor. I don't know, probably. Pain generally is a very subjective matter. It not only depends on the patient's perception of pain, but also the patient's previous experience of pain. So, for example, the most painful experience I've had in my life was a broken leg. Whereas if you speak to someone who's had, I don't know, what's the worst ever pain you can have? Giving birth, maybe. Probably their pain threshold will be a little bit higher than mine. So maybe because they're young, they haven't experienced so much pain. That's why their pain threshold is a little bit lower than elderly. I don't know. It's just an explanation from top of my head.
Yeah, maybe we spoil our juniors. Maybe they are spoiled.
That's the explanation I didn't want to say, but you're right.
Yeah, no, but on the other hand, I think biologically speaking, we may say that the inflammation in the young people may be more exacerbated or something like that. What do you think? Because the inflammation level in the young people may be more than the aged group. I don't know, just a suggestion.
Possibly. From a biological point of view, I don't think I have come across a study that assessed the difference in terms of response of inflammation, and correct me if I'm wrong, comparing younger patients to adults or to elderly patients. But you might have a point. To be honest, I'm not sure if I could add anything to
I have seen actually some publication about the level of the inflammation and the level of the response of the young people to inflammation in comparison to the aged people. So that can be some issues. Maybe you look at that for the next publication, because in the next publication you are looking for the healing, and the level of the healing is actually higher also in the young people because of the initiation of the higher inflammation, because inflammation is the initiation of the healing as well, but it is something else. Okay, and also the preoperative pain, obviously, similar to many other studies, and the intensity of the pain before treatment strongly predicted the likelihood and severity of the post-operative pain, which we have already discussed that one. But what about the apical diagnosis? The condition of the tissue at the apical area significantly influenced post-operative pain, as I mentioned here. So can you tell us something about that? Because it is also another confounding variable, apical diagnosis. How do you manage this?
I think we briefly tried to explain this in the discussion. If I want to explain it in a way that's not mentioned in the discussion, I would probably add something else to this explanation. I would say that sometimes if you have multiple outcome measures, one might show significance just by chance. And that might explain why we've had a significant difference with apical diagnosis. And I personally tend to lean more towards that explanation than any other. So other than that, really, I'm not sure if I can give a plausible explanation for that finding, to be honest.
Okay. So that can be another open question for your future studies. And hopefully, again, in terms of healing, you may find something more than that. But obviously, I think when we have apical pathosis, the possibility to have post-operative pain in other studies also confirmed. So your finding is not different from others' finding. So I know because of the limited number of the cases with apical pathosis, you are not able to confirm that easily. But on the other hand, it is not actually far from other studies. Again, if there is any question from our colleagues from around the world, I can see actually Professor Vajih also connected to us and a lot of other colleagues. If they have any concern or any question or any comment, please
I have a
just...
question.
Yes, please, Hugo, go ahead.
Yes, I have another question. In the results sections, when I was reading the manuscript, one statement called strongly my attention was, I'm going to read the statement. One participant with one treated tooth declined to submit the form due to dissatisfaction with the treatment received. In backstage with us here, what happens with these patients, with these participants?
I wasn't on clinic. I just remember looking at the notes and asking the supervising faculty what happened. And basically, it was a patient who waited too long for his case. And then when the case was finished, he was not happy. So he wasn't answering our phone calls. And that's the case, really. It was a case of waiting too long, fortunately, for their appointment.
Yeah, it
sometimes
happens. Yes, it happens.
I'm glad it was just...
No problem.
Was he another young patient? Okay, let's move on until if any of our participants, lovely participants, wants to add anything, please just turn on their microphones or raise their hands, then we are able to turn on their microphones. Okay, discussion. Obviously, we discussed a lot so far, so we clear off a lot of things. And oh yes, there is a question. Please go ahead. Unmute yourself and please turn on your video if you like. Aisha Faisal, please go ahead.
Hello, Assalamu alaikum. Can you hear me?
Wa alaikum salam. Yes, we can hear you very well.
Okay. I just want to ask, is there any difference in postoperative pain regarding, like if you consider the gender, like male and female?
Yep, good question. Fahad, please.
Yes, in our study, there was no difference. In other studies, you might find that some did find a difference. They found more postoperative pain with females than males. Others didn't. In our study, there was no difference, no significant difference. So to answer your question, with concern to our study, there was absolutely no difference between the two genders.
Okay, so based on other studies, do you have you expected something like that to find out any difference between genders, Dr. Fahad?
I mean, to be honest, it's one of these things that I wouldn't have been surprised any both ways if we found a difference or not, because this has been studied widely in the past, and there was so much data favoring one way or the other. I just hope that the data we present can be used someday to combine them all together and see whether there's a true difference or not.
Yeah, and I think for such a thing, definitely a multicentral study can solve the problem. So we need some sort of multicentral for that purpose, because different genders in different countries, they may have different approach. As you mentioned, the pain is a multivariable things to evaluate. And you explained very well about the worst pain that you experience or somebody else experience. So ladies may have some experience about the pain that we couldn't even imagine, which is childbirth. So this is very difficult to say that, because the threshold and the way that they can tolerate with pain, I would say that is much, much better than the man. I personally find it out in comparison to my wife, she can tolerate with pain easier than me. And small pain, I will shout. But for women, they can tolerate everything. I don't know, is it the case in Mexico, in Kuwait, in other countries? I don't know.
Well,
Maybe I myself can say.
every time I get the flu and I tell my wife that I'm not feeling well, she rolls her eyes. So
Yes. No, when I have pain, I start writing my willing very soon because I say I'm going to die. It's always like that. Okay, let's move on. Any other question from anybody? Thank you very much, Aisha, for your question. Any other question? Any other comment? Please go ahead. Okay, for discussion, as we already discussed, the limitation, which I find it out also, is about the subjectivity of the pain that Dr. Fahad already mentioned. And the discussion, the way of the writing the discussion was superb. I find it that very, very interesting. And I learned from that, Dr. Fahad. Honestly speaking, I learned from the discussion part because I personally believe that the discussion is the heart of the publication. And whoever can write the discussion very well, like that you did, is actually showed that your background knowledge about the pain is very good. And pain is a very difficult subject, very difficult subject. So I prefer actually to see more deeper exploration of the limitations, as you already mentioned that some of them are missed. And also you haven't actually mentioned something about the future research. I tried to find something about the future research. By the way, Dr. Veggie from Finland wants to have some question. Let me try to find the way to. Yes, Dr. Veggie, please unmute yourself. I think one of the reasons, yes. Dr.
Okay,
Veggie,
now I am
yes.
unmuted. Yeah. Hello. Hi.
Good, good.
Thank you. Thank you for inviting me and thank you for a great meeting.
Thank you for joining us.
And nice to see you, Dr. Nekoofar, after a long time.
Thank you.
Yeah. Okay. I'm sorry I joined a little bit late and I missed the start of the conversation and the discussion. Just wanted to go through, I was not able to go through the article also thoroughly. So I just wanted to ask a brief question was this treatments done in a single visit or multiple visit?
Okay,
thank you
Dr. Fahad, please.
Thank you. Question. Some treatments, I can't remember, I can look at the table and have a look. Some treatments were carried out over multiple visits.
Okay, because in my opinion, when I heard the discussion, this kind of study would have been much more relevant if all of the treatments were done in multiple visits, because you know that sometimes the acute flare-up happens in the initial treatment beginning. So if we are going to evaluate the obturation, differences of operation, then it should be, in my opinion, be done after the second visit, and then you will get a much more detailed observation. Thank you.
Thank you very much for your question. I see the point of limiting it, I would say, to either one visit or two visits, to have a similar circumstances. However, carrying out both of them for two visits just because there is an increased chance of flare-up, I'm not sure if this is backed up by evidence, to be honest. What matters is a single time point in this article, which is post-obturation. So I could argue, and allow me to do so, to say that whatever happened before that in terms of number of visits shouldn't really have an effect, because I'm looking at post-obturation pain, a single time point. Although realistically it might have an effect, at least theoretically, I don't believe it has that much of an effect. Finally, if we would do that, carrying out two visits just for the sake of ensuring that everybody's standardized, I'm afraid this would go against our institution's code of practice. And I'm pretty sure most of you have carried out research. It's always a game between doing the perfect research and doing what's best for the patient. And think we probably have managed to find the sweet spot in between.
All right, by the way, that is an issue. I think the issue that Vajul mentioned is very important to look at the previous article as well. Some articles try actually to standardize every details. So you may say that this is a limitation of the study because, as you explained, of the policy and ethical approval and everything. But on the other hand, studies showed that the most important reason for the postoperative pain is actually the preparation of the canal, but not the obturation. So how do you manage this to make sure that you are not having another co-funding variables? I think that is the issue that Dr. Vajid tried to set.
Well, absolutely. Again, we go back to standardization. We know, I think there's enough evidence to show that instrumentation, possibly using reciprocating more than non-reciprocating files, would probably contribute to more postoperative pain. More definitely, over instrumentation leads to postoperative pain. So I think by overcoming these and minimizing this using ProTaper Next as a rotary system, ensuring that our preparation is within the working length, doesn't go beyond the apex, and we did that by using electronic apex locators and the use of working length X-rays. I think this probably reduces the risk of severe postoperative pain in relation to instrumentation. But however, unfortunately, this could never be ruled out completely.
Yeah. And there are some very important messages in the chat box. One of them by Carolina, that she mentioned that it may remove the preoperative pain effect on the post-operation if we do the treatment in 2 visits. And in the first visit, if we just do the cleaning and shaping, waiting for the relief of the pain, and then we just concentrate on the effect of the obturation variable on the postoperative pain. What do you think? I think we can say that it can be the limitation of the study. And by increasing the number of the sample size, it may be sorted.
Absolutely. And I think one of the papers I've referenced in my manuscript did that exactly, where they did not obturate until the pain was completely gone. Yeah. Because again, this was a secondary outcome, we couldn't do that, unfortunately. So we had to compromise in a way for us to be able to look at the bigger picture.
Okay, thank you. I think Aisha have another question. Aisha, please turn on your microphone and ask your question. Aisha Faisal, please. And thank you very much, Vaji, for the issue that you raised. And thanks for the comments in the chat box. Also, people ask for the article, and I think somebody provide you the article. So in the chat box, you can download it from the chat box. Aisha, do you want to ask your question? Please go ahead.
Hello.
Hello, we can hear you very well. Yes, go ahead.
Okay, I just wanted to ask how you are going to standardize if you are doing the treatment in one single visit and versus the multiple visits. And in multiple visits, have you used any intracanal medication or like Ledomex paste? Have you seen the effect of those things on the pre or post-operative pain in case of multiple visit root canal treatment?
Thank you. I think I've sort of answered the former question. To answer your latter question, we all used calcium hydroxide, so we didn't use multiple medicaments. Calcium hydroxide was the only medicament used in this trial.
So are you going, Fahad, to give us some, maybe it is good to do that, it would be good to do that, give us different results from single visit versus multiple visit, because you already mentioned that in your cases, you have some of them by single visit, some of them by multiple visit. Am I right?
Absolutely. I mean, if you look at the systematic review that was published probably a decade ago, which is the most commonly referenced paper in terms of single versus multiple visit endodontics. They looked at mainly outcome of endodontics, not postoperative pain. In terms of postoperative pain, to be honest, I don't remember coming across a paper where I was satisfied with a significant result when it comes to postoperative pain using singular versus postoperative pain studies are very difficult to standardize. And unfortunately, they rely heavily on the patient reporting their symptoms. So it's not a subjective evaluation. It's a very objective evaluation. Personally, with my practice and the research I've read, my sort of understanding of this is that I don't personally believe that carrying out treatment over 2 visits has any benefits in terms of postoperative pain. If anything, there's a risk of calcium hydroxide extrusion that might cause postoperative pain.
Okay. Yep, Aisha, carry on. I think Aisha still wants to ask the question. Aisha, carry on.
Have you checked the effect of supraocclusion? Like the most common cause of postoperative pain after endodontic treatment is the high filling. What you did about that?
Absolutely.
Sorry, I joined the meeting late, so that's why I'm asking this question.
Thank you, Aisha, for your questions. Yes, we did, and we did mention that in the methods part. We made sure that the tooth was in harmony of occlusion. We checked it in protrusive and lateral occlusive forces. So this was one of the points that we made sure would not affect the postoperative pain evaluation.
Okay, that's great. Thank you very much. Because of the time, I'm going further about sample size. I think we already covered this question and the previous question as well. Therefore, I move on. And if I say about the strengths of this study, what was the strength of this study? First, I would say double-blind design and high response rate, 99.5%, except one young person that you already mentioned, and also relevance, finding applicable to clinical practice, definitely, and also for the standardization, the calibrated operators and uniform protocols raise actually my attention, and I really like that the way that you mentioned that you had a teaching session even for the colleagues, experienced colleagues, and that was really a good one. Limitation, I think we already mentioned about a lot of things. Obviously, the pain studies, they have a lot of limitation. Pain as a secondary outcome, not fully powered. We mentioned that. And then we also mentioned that in comparison to other literature, it is already covered. About the baseline imbalance, the way that actually they allocated in the sealer-based obturation group was really good. So we did, and also about the inclusion criteria, the only things that we were worried about that was the use of analgesic before initiation of the treatment. That is still there, and pain is a subjective issue. So we are not worried about these things at all anymore. So Aisha, please go ahead and ask your question. Because we already covered the study and we're almost at the end of the session. If there is any question, please go ahead, turn on your microphone, and if you like, turn on your videos as well. Aisha, please unmute yourself.
So
I think Aisha, when you turn on your videos, the coverage of your internet is a bit low. We cannot hear you very well.
Okay,
Please turn off your video.
Can you hear me now?
Yes, better, much better.
Okay. So I want to ask the principal investigator what is his in his mind, how he can convert this study to a multiple center study, keeping the standardization and all the things in mind.
Thank you, Aisha. As well, we probably covered this part before you joined us. Again, I said the next step would be to do a multi-center, and it's not an easy thing to do, as I explained earlier. It would be a challenge, to be honest, but I think, yes, this would be the next step.
Okay, great. Hugo, do you have any things to add? Please go ahead.
No, everything is okay. Only congratulations, Professor Fahad. Great manuscript. Thanks for attend your invitations.
Thank you very much.
Dr. Fahad, thank you very much. You have a very, I would say, familiar face to us. And also, we think actually we are at Kuwait in your school, and you are a very good teacher as well. So I'm going actually to ask my colleagues to share the certificate on behalf of the SELA and Tehran University of Medical Sciences, which is co-signed by both institutions. And in the chat box, we have received a lot of compliments about this session. Very informative. Congratulations. A lot of things in chat box. We will send you that one as well. خانم صدیقی لطفاً share بکن نتیجه رو با ما. Professor Kazandak, do you have anything to add? Please unmute yourself. We cannot hear you yet. Thank you very much, all of you, for joining us. Let's put our hand together for Dr. Fahad Alzoubi for this amazing job. Thank you very much, Fahad, and we will send you this certification as well. So, yes, Marriage, please go ahead.
Okay. Can you hear me now?
Yes, very well.
Okay, congratulations. I'm in the United States now, and I joined the meeting very lately. Sorry for that. I've just seen your message, but I understand that the article is very well planned and conducted. Thank you very much for sharing.
Thank you very much for joining.
Good to see you all, and thank you very much for being with us. And the good news is we have this gathering every month, which is actually based on the support of the SELA, which is the Confederation of the Endodontic Societies of Latin American Endodontic Societies. And with the leadership of these amazing leaders of SELA, we are able to see each other every month and discuss in this scientific way. And the compliment that we receive from you guys, the participants, give us more energy to move on. Obviously, our resident, postgraduate resident can join for each session and enjoy and learn from that. I understand that in some centers, they use this as one of the teaching sessions. So we have people under one name, but with, for example, 10 students attending the sessions. That is great. Dr. Fahad, I know this is a very difficult job to sit in this hot chair and answer this harsh question. And but I'm very happy that you answered every question very confidently, which is showed that you did your study based on the scientific methodological background. Thank you very much indeed from you.
Thank you,
so
Doctor.
I want to ask Carolina on behalf of SELA leadership to terminate the session. Carolina, please.
Great. Congratulations, Dr. Alzoubi, for your participation. It was great to have you here with us discussing your wonderful article. We would like to thank also you, Professor Nekoofar, for leading the session. Always great. And also all of the meeting attendees for your time, and invite you to the February session when we are going to have Dr. Flavio Alves from Brazil. So see you next month. Thank you very much.
Bye.
Thank you all. Dr. Fahad, last word, if you want to say anything, please go ahead.
Absolutely. Well, thank you very much. I've enjoyed this as much as I thought I would have. So I really look forward to future collaboration with both Tehran University for Medical Sciences and the South American Endodontic Society. Thank you very much. I will definitely be joining in your next journal clubs. and hopefully my residents at Kuwait Board of Endodontics, I will probably force them to join.
Inshallah, inshallah.
Thank
Thank
you.
you very much all. Have a very nice day in Mexico and in America. Have a very nice morning, and for us, very nice evening and night. Goodbye, everybody, and see you in a month.
Take care.
Bye-bye,
Bye-bye.
Hugo.
Bye-bye.
Goodbye. Goodbye. Oh, see, this is the group that I told you. The students. Thank you very much. We know that.
Bye.